question how actually we can define these issues, because everybody is talking about structural atrial disease. However, the structure may differ substantially in various patient subgroups. For that reason, I think it's very important to have a classification that can be used worldwide really to describe what the problem is, because we are talking about individualized medicine, but I believe that atrial fibrillation is not atrial fibrillation, and it's the same, it's really different, and I think that the structure really has an impact. Because, of course, we know that reduced ejection fraction, of course, is a marker of ventricular cardiomyopathy. However, we do know that there are different entities, and we do know that these entities like reduced ejection fraction or preserved ejection fraction needs different therapy, although everybody with heart failure is a heart failure patient. So, but what is an atrial cardiomyopathy? And we know from many trials and research results that, of course, atrial cardiomyocytes react quite rapidly, probably more faster than in the ventricles, and we do see substantial alterations, and of course we do know that we have a degradation of myocytes, an increment of fibroblasts, for example, and we know that atrial fibrillation itself has an impact, but it's just a single factor in a whole scenario of different parameters leading to hypertrophy or death of atrial myocyte. So for that reason, actually, the EHRA put together a consensus report committee, and we published our results last year. So we tried to have a global assessment including all the different arrhythmia associations around the globe to put together a definition of an atrial cardiomyopathy, how is it defined, and what potential consequences it may have. So we came up with a very broad definition of an atrial cardiomyopathy as any complex or structural, architectural, contractile, or electrophysiological change affecting the atria with the potential to produce clinically relevant manifestation. So it's very broad. However, I think that this can really now be at least the basis to deal with different scenarios. And what we also did, because we do have many papers dealing with structural atrial fibrillation, but we think that there are tremendous differences. We do know that there's atrial fibrillation in the presence, for example, of hypertrophy. However, we of course have hypertrophied atria without any atrial fibrillation. So we defined different EHRAS classes, 1 to 4, where we can actually define pathologically how the tissue is affected, like pure cardiomyocyte dependent or predominantly fibroblast, a mixed type, or different compounds. And later on you will hear about adipose tissue, for example, or inflammation. So, and this is the EHRA class with the different categories. And just to highlight different pathologies, you can see, like EHRAS 1, that these changes are within the myocyte with glycogen accumulation, for example, and hypertrophied cells. And we do know that hypertrophy itself produces anisotropy, which may lead or not to atrial fibrillation. We do have fibrosis. We do know that nicotine, for example, or aging process interferes with collagen, and these are typical scenarios where the muscle looks stable and normal, but we do have interstitial collagen accumulation. And of course, we do have a large group of patients with cardiomyopathies, ventricular cardiomyopathies, where you do see substantial alteration of both myocytes as well as the interstitial matrix. And of course, we do have a large scenario which is not considered or mentioned in many papers, and this is that we of course do have many alterations not leading to fibrosis per se. So we do have interstitial alterations, and I'd like to spend a couple minutes on this, because this is usually not reflected in many trials, because everybody just talks about fibrosis, which is of course in many cases really the case and important, but not in all the patients. And one impact is amyloid. We do know that there's a scenario of isolated atrial amyloidosis, and we do know that we can now identify patients, especially the elderly ones, who do have massive accumulation of amyloid. And the question is, what is amyloid? So amyloid is actually a conformational disease where a protein is misfolded and then just stored because it's not degraded in the usual fashion. And we do know that many organs can be affected by amyloidosis, like the brain in Alzheimer's disease or especially the AHRA, and isolated just the AHRA. So the question is that related to fibrosis, for example? And we did a large study with more than 240 patients, and we analyzed the biopsies, and we could clearly show that the amount of amyloid found is inversely correlated to the amount of fibrosis. We do know that it has a direct impact on P-wave. For example, we do know that gender is an factor because women have a higher tendency to develop isolated atrial amyloidosis than men, and especially in valve diseases. So I think this is an interesting impact because we have to deal with these specific cohorts. And the question is, how can that be, or that just an isolated finding? There are other studies also showing that in particular the left atrium is involved instead of the right. We do know that there is a particular distribution of amyloid, and this comes out in many trials, that there is a gender impact. So female gender is a factor driving the development of atrial amyloidosis. So the question is, how can that be explained on a pathophysiological level or molecularly, why this happens? And we do know, of course, that the receptors for estradiol are expressed in cardiomyocytes, and they, interestingly, interfere with hypertrophy of cells and ANP synthesis. So the question is, can actually estradiol drive throughout the lifetime the synthesis of ANP as a protein, which actually leads to amyloid in the atria? Because the protein providing amyloid is ANP, misfolded ANP in the atria. So we have actually shown that these receptors are present in male and female biopsies, and we do have substantial impact on various molecular markers by estradiol. So what we can show, and this is just a summary, that of course atrial stretch and all these factors interfere with ANP synthesis, that this is altered by the presence or absence of estradiol, that we have an overproduction of ANP, and we do have an impact then on the development of misfolded ANP molecules and proteins, and then the development of atrial amyloidosis. So this may actually induce why we have, especially in elderly female patients with moderate degree of valvular disease, in particular high levels of amyloid present in left atrial tissue samples. And that may be a different scenario of structural alteration leading to atrial fibrillation in this specific scenario. However, we also know that, and this is just one clinical implication, that atrial fibrillation may cause dementia. However, Alzheimer's disease, it's much more common than just cognitive decline due to massive multiple cerebral emboli. So, and we do know, of course, that Alzheimer's disease is an amyloid disease. And the question really comes up, if we do have a similarity in pathophysiologically explanation, why actually atrial fibrillation and Alzheimer's disease is linked, probably due to misfolding of proteins. So this is just a hypothesis, but it would explain at least why Alzheimer's disease is the predominant way of cognitive decline in AF patients. And we will hear later on that, of course, fatty infiltrates are important, and we do know, for example, from the pericardial fluid that, of course, we do have segregation of different factors and hormones in the pericardial fluid, also coming in particular from adipocytes on the epicardial layer, and there also are substantial differences between gender. So, and also we do have inflammation, of course, and with all the different scenarios. And so the last point is, and you have also heard in Uli's talk, that we truly believe that these factors not only interfere with the contractility or electrophysiological properties, but also with thrombogenesis. And we have shown clearly that the PAR receptor is present, in particular PAR1, PAR2 receptor, that can interfere with this. And we do know from all these factors in the Chatz-West parameters that all these alterations actually interfere with molecular biology of the AHRA, and we do have an endocardial remodeling even in the process where atrial fibrillation is not there, and we have to deal with these molecular alterations, which can clearly be defined, like especially the lack of nitric oxide, which can clearly cause ischemia also in the atrium, but also interfere with the clotting system with all the different parameters. So I think that this paper actually might be worth really to be considered and to be read, and because it could be the basis really to have a more precise definition of the different structural type of atrial fibrillations, really to deal with different cohorts, define different cohorts, and we have to see if these cardiomyopathies are the egg or the chicken, because I think that is now then the title of the next talk. Thank you. So, and as I just said,